Welcome back, everybody, to this month's audio-vestibular medicine case discussions. And we have a guest presentation today from Bulent Mamikoglu and his medical student, Christian Ortiz. Um, we just to, let's see, what happened? So just at my little disclaimer, I have to read for everyone. We're having monthly presentations of interesting cases in audio-vestibular medicine. I am one of the hosts, Gerard Gianoli. Our other hosts are Dr. Mohamed Hamid, who's with us from Egypt today, and Eugen Ionescu, who unfortunately could not meet us. He has some other academic duties, some meeting in France. I forget exactly what it was, but everybody is encouraged to participate. The information discussed is meant solely for educational purposes and not intended as medical advice for any individual. For individual medical advice, please seek the counsel of your physician. While these conferences are geared toward medical professionals, patients are welcome. However, we will not discuss individual patient cases in this setting. Please speak to your physician for individualized medical care. We are archiving the recordings of these discussions on our website, and that's at youtube.com/at AVM case discussions. And for today, we have, as I mentioned, guest presenters. We have Christian Ortiz, who is a second year medical student, and we're quite impressed to have a second year medical student doing such a talk on something that none of us know anything about. And then his mentor, Bulent Mamikoglu, who is a good friend up at New York Medical College, who is a neurologist who did his fellowship in Chicago with Rich Wyatt. And I am going to turn it over to you guys. And if there's any questions, I'd say let's just interject as we go along because I think this is going to be a very interesting discussion. All right, Bulent, do you want to take it from here?
Yes, let's have the first slides.
All right, I am going to stop my share and you guys can go ahead and share.
So this summer we did IRB approved this study about this caloric posture vibration, and we tried to probe into phenotype of the velocity storage. I did those experiments with Christian, and so he's our medical student. He's going to take it over. At the end, we will have a very, very short case presentation and future directives, and we are looking forward to get the opinion from the experts, Art Hamid and Dr. Gianoli. Let's start.
So why velocity storage matters. Velocity storage is a brainstem cerebellar network that prolongs vestibular signals. The semicircular canals themselves respond only for about 5 to 6 seconds, but because of velocity storage, the vestibular ocular reflex can persist for about 15 to 25 seconds. This mechanism helps stabilize our gaze during rotation and contributes to motion perception. Clinically, abnormalities in velocity storage are believed to contribute to conditions such as vestibular migraine, motion sensitivity, and visually induced dizziness. However, most clinics do not measure velocity storage directly because rotary chairs are not widely available. So a short history on velocity storage. The concept of velocity storage first originates from the 1960s and 1970s, where researchers observed that eye movements during rotation lasted longer than expected from semicircular canal mechanics alone. Robinson and colleagues proposed integrator models for the vestibular ocular reflex. Then later on, Cohen and Raffan formalized the idea of a central velocity storage mechanism that prolongs vestibular signals. This system is now understood to involve brainstem vestibular nuclei and the cerebellar nodulus and uvula. Velocity storage mechanism, what is stored versus what modulates it. The velocity storage takes the angular velocity signal coming from the semicircular canals and prolongs it through a leaky integrator network. However, the stored signal is not fixed. It can be influenced by several factors, these being visual fixation, gravity signals from the otolith organs, and a central physiological state. These influences can suppress or reshape the stored signal. The semicircular canals provide angular velocity signals. Then the velocity storage prolongs that signal through a leaky integrator. Otolith and visual cues can modify or suppress the stored signal, and thus the final output depends on both peripheral input and central modulation. How velocity storage is tested in clinic and where our protocol fits in. In research and in specialized vestibular centers, velocity storage is typically measured using rotary chair testing. One common method is sinusoidal harmonic acceleration, where the readouts give us gain and phase, and velocity storage is most visible at low frequencies, and this is good for frequency domain characterization. Another is the velocity step test, where the decay of I velocity is used to estimate the time constant of velocity storage. And finally, there is tilt suppression. Unfortunately, in many instances, rotary chairs are not available in many clinics. So our study objective. We hypothesized that velocity storage might be probed using a simpler clinical paradigm. Caloric stimulation can produce a sustained low-frequency vestibular bias that effectively charges the velocity storage network. Changing posture alters the gravitational reference, and a brief mastoid vibration stimulus may act as a perturbation probe. Together, these steps may reveal how stable or unstable an individual's velocity storage system is. Our goal was to characterize velocity storage dynamics across 3 example phenotypes: a neurotypical control, an individual with vestibular migraine, and a vestibular trained athlete, that being a dancer. As to what we did. First, we performed a standard caloric irrigation with 50 milliliters of water. We did warm calorics at 44 degrees Celsius, and we also did cold calorics at 23 degrees Celsius. We did this with the patient supine, and the head elevated about 30 degrees. Then we sat the subject upright.
Christian,
Yes.
Christian, can I just ask, the calorics, they were water calorics?
Yes.
Okay.
So after the supine caloric, we sat the patient upright. This reduced the caloric convection and introduced tilt suppression from the otolith system. Third, we applied mastoid vibration for approximately 3 to 5 seconds at 80 to 120 hertz, depending on the massage gun setting. Afterwards, we returned the subject to supine position while we continued to record the eye movements. In this case, the vibration from the massage gun acted as a small perturbation probe to test how stable the test subject's system was. Using video oculography recordings, we would like to extract several measurements. These included the peak slow phase velocity during the caloric response, the decay profile of a slow phase velocity, the degree of suppression when the subject sits upright, the response to vibration, including amplification or reversal, and the presence of a phase 2 rebound when returning to the supine position. The decay phase of the caloric response is where velocity storage becomes visible. In measuring the decay slope, we can estimate how strongly the velocity storage network is contributing to the response that we're seeing. The caloric decay reveals velocity storage behavior. A key part of the protocol is measuring this decay phase of the caloric response. If only canal mechanics were involved, the response would decay quickly. However, velocity storage prolongs this response. By plotting slow phase velocity over time and fitting an exponential curve, we can estimate the effective time constant of the system. In measuring the decay slope, we can estimate how strongly the velocity storage network is contributing to the response. One example of this, where this would be interesting, is in somebody with vestibular migraine, where the velocity storage system may be poorly damped. This is a hypothesis currently believed by many clinicians. In this could produce fluctuating slow phase velocity and stronger responses to perturbation, which is where we move into talking about velocity storage instability. The decay time constant reflects how strongly the velocity storage network is contributing to the response. A longer time constant suggests stronger velocity storage. Changes in decay behavior may therefore reveal differences in vestibular integration across individuals. Normal canals does not equal normal vestibular integration. An interesting paradox that exists is seen in vestibular migraine patients, where many standard vestibular and canal tests appear normal, tests such as VHIT or standard calorics. Yet patients still experience significant dizziness and/or motion sensitivity. This suggests that the problem may lie in the central vestibular integration rather than peripheral canal function. Why velocity storage may be distorted in these individuals. Our proposed hypothesis links pressure dynamics and otolith bias. One possible mechanism involves interactions between intracranial pressure, venous outflow, and inner ear pressure. Changes in these systems could subtly bias the otolith organs, and it is this bias that might distort how the velocity storage system interprets gravity, producing abnormal vestibular responses. So again, our working hypothesis is that the vestibular migraine may represent a disorder of graviceptive control of velocity storage. Another way to describe it is that the system that normally stabilizes vestibular signals relative to gravity may become unstable in these patients. Here we have 3 illustrated phenotypes from the participants that we had. We had a neurotypical control that demonstrated an expected caloric direction and modest modulation with vibration, and a small and brief reversal with vibration. Then we have a vestibular migraine, which represents a hyperexcitable velocity storage that showed signs of stronger damping/compensation and smaller stabilizing vibration effects. And so as thus that the vibration can re-express the primary direction of the caloric response and would provoke symptoms of vertigo, those being extreme vertigo, nausea, and dizziness. And then we have the elite dancer/skater phenotype, which is a trained velocity storage that has signs of stronger damping and compensation and smaller vibrational effects. These groups help us interpret the patterns as central regulation differences rather than fixed peripheral deficits. If this hypothesis is correct, then changing head orientation relative to gravity should alter the system's response to perturbations such as vibration. This prediction can be tested with the same subject by repeating the protocol with different head tilts. So with this slide, we're really trying to show the logic of why a brief vibration probe can reveal a different behavior than the standard caloric readout. As you can see here, the orange curve is the conceptual slow phase velocity over time during a typical sequence. We start off with a supine caloric, where the SPV builds up and then starts to decay. The blue squares that you see right here are just conceptual sampling points showing the measured signal tracking the curve. Then when we place the patient in a seated position, seated upright, the SPV drops sharply and stays low. This is where 2 things happen at once. The caloric drive geometry changes. There's less effective convection because the individual is now perpendicular to the Earth's gravity. And the gravity/otolith cues suppress the stored component, a tilt suppression, a central gating. Functionally, the system is now in a state where the net output is near 0, what we labeled here as vector aligned, or minimal nystagmus. Now we have the vibration period, where during this low output period, we apply a short mastoid vibration. The key observation is that the vibration produced a small, often reversed nystagmus. So it's not just amplifying the residual caloric nystagmus, it's acting like a perturbation that taps a different route and can reveal instability or reweighting. And then we place the patient back in supine. And when they return to supine, the caloric nystagmus reemerges, usually weaker than the initial peak because the stimulus is further along in its time course and partially decayed. At the bottom here, this is a schematic that explains a possible mechanism for what we were seeing. And we've separated two routes, a regular afferent weighted / indirect route driven by the caloric response down here that feeds into the central integrated network and produces the main vestibular ocular reflex output. Then above here, we have a irregular afferent weighted with a direct pathway that is recruited strongly by brief vibration, elicited showing a fast, high salience input that can transiently influence the output even when the indirect route is suppressed. So the take home with these two diagrams here is that vibration is not just more caloric. It's a short perturbation that can expose how the central network is gated and how stable the system is, especially during decay and posture-dependent suppression. And that's why we often see the vibration effect most clearly when the caloric response is weakening. The system is closer to a transition point, so any amount of perturbation can produce a disproportionate change.
Christian,
Yes.
can we go back to the previous slide? What is
Yeah.
the time scale that we're talking about here? Starting 0 second, or is it post the caloric? And what's the end?
So we would start the time after the final water caloric had been inserted. So once we started seeing a caloric response, and we had let the test run until the nystagmus would essentially be 0, where we would see no response back in the eye.
Okay.
So that could be anywhere. For some patients, it was about 6-7 minutes. Others took a little bit longer for all the nystagmus to go away.
So we already have started. This is the 0 point where we finished the beginning of the slide is the 0 point where we finished the caloric. We already see the response. We're waiting until reach to the peak. Once they reach the peak, we have the subject to sit. The top of the curve is where the patient sits. That's how the mechanism starts. Once it's up there, we have to put the patient sitting position.
Was there a consistent time that they were seated, or was it based on watching the declining slow phase velocity?
They all kind of reach to this reach around once we are finishing in there about we did 50 ml. We didn't do it like we do regular on calorics, audiologists do. For our protocol, we use the 50 ml and injections. So it takes around 30 seconds to do that, complete it. So once there, around the 10 seconds, we added there, we reached quite a bit on the peak there. We can see it from the walk results. We get it around the 30, 35. That's our peak in there. And then once we reach there, we have it. We look at also the average things, what they are reported. What are these? Looks like the 30 is the average time to reach the slow peak velocity.
And how long did you do the oscillator for?
The vibrator, we use it for a few seconds.
Okay.
But what is, if we look at the curve, I don't know whether you're seeing my pointer or not. You start the caloric, you reach the peak, it drops sitting, and at what time exactly where your arrow is? Approximately, is it 2 minutes here, 3 minutes?
No. The time frame, we didn't put it on perfectly. We kind of do it on the fast in that part. Usually that slope is changing with the patients in there. In an average, the normal ones, we see that slope go down around 30 seconds.
30, okay. And then the sitting would be, if we go all the way to the flat line, that would be in seconds post stimulation time. What would it be?
Yes. So what we are doing is we have to understand this is a pilot study, so we are not really sure what we're going to find out in the beginning. This slide is mostly been taken from our case number 2, I believe, in that part. So once we put it in there, so around this time, when you if you see the slides here towards the vibration, it's around 30, 35 seconds we're seeing there.
I would agree with that, that the nystagmus duration is usually about the same in all patients. Patients who aren't bothered much by calorics, the nystagmus dies off about 30, 45 seconds. Patients who are extremely symptomatic from calorics, that's not because the nystagmus has persisted. The nystagmus has gone away. They still feel horrible and awful, nauseated, vomiting, but that's not because the nystagmus is persisting. So I would agree, most patients, the nystagmus duration, I think, is about the same.
Yes, so you're right in there. So can you see my arrow or no? You can't.
No.
Let me take it 1 second. Where is it? Let me share my screen. Oh boy. The screen is become a complicated screen. Gosh, all right. Here, can you see me? Can you see now?
No,
No,
I
not
see
yet.
Zoom
it
screen.
says Zoom.
Yeah. All right, so Chris, you have to help me, okay?
Yeah.
Let's see. Let me take out from the share. Stop sharing.
Yeah.
So there is another line that we want to put it, but we couldn't put it on the right way.
Maybe it might be easier once I stop my share.
You stop your share?
Yeah.
Okay, let's go and then find my. I didn't open my slides. Gosh, all right. Then I will find your slides. All right. And then vibration. Ortiz. All right. And now, so I need to share my slides. Share view. Slide control. Nothing. I'm seeing nothing in there. All right, 1 second.
I think let me reshare my screen, and I think I can give you like privilege to
There we
also
go.
move my
I got it.
slides.
Okay.
Okay, sounds good.
Right.
Oh, there it is.
Okay.
Yeah.
You see me?
Yeah.
Yeah, we can. Yes,
Okay.
we can
Yeah.
definitely see it.
So this we tried to put the blue line, but we couldn't put it. The blue line keep in there. So the line should be here. That's the once we have the peak, we are expecting to peak like this, go down, and then reach here. If we have the caloric run completely. And this is approximately runs for the 2.5 minutes. It's
2.5 minutes. Okay.
Yeah.
So
So they're there, and then but during this time period in these two sections, we interrupted the caloric response by having the patient go back to sitting position, where we
yes,
aligned the vectors, so we stopped the nystagmus. But the charge is still there in the velocity storage. So it is still charged. So the brain
yes.
did not forget it. Once we put the patients back, it resumed in there. Here on that part, the regular and irregular for histological point is a Goldberg and Fernandez theory. So they worked a lot. So they have been thinking about that certain efferents are regular. You guys probably know that much better than I do on there. And then the irregulars. In our perception is that regular efferents are the ones that actually charges the velocity storage. Indirect one doesn't go through the velocity storage, it goes directly in there. So the irregular one is the fast movements, such as vibrations, such as V-hit test, because you get it or not. Physiologically, when you're thinking about that, you have to have this response immediate. You cannot have those to wait little bit in there, it has to be immediate. And vibration is one of the things that has been considered in that part. If the doctor, there's a French and what was his name? There are important researchers. I can't remember the name. Oh gosh, sorry when it's in there on that. But the irregular ones is being used in that frame. So you get it or not. So when you probe the ear person, we are actually going through the velocity storage. We are not in there, but normally we don't see that on the patient when we pre-test the patients. So it gives us an interesting gate, opens up a small gate to us to see this vibration response on these patients. If we can forward to this slides in here, this is another schematic. Normals, that's what we see like this, as there, set, and then vibration. Dancer was perfect. It's like a picture perfect. We see it very fast in there. It's been stopping. But in the migrainer, when we try to do that, that was a disaster for the migrainer. First of all, it hardly do anything. Vibration doesn't do that. And when we tried the vibration again, she started profusely vomiting and then cannot hold it on that part. So from that point of view, we are thinking that that simple model can be built on that part. Remember, this is a pilot study. So we will have better gating as it's what's happened, maybe the normals. Patients with the dancer is much more improved on there. And then we have the migrainers that we don't get the dumping and the other findings. Any questions so far?
So you guys have done 3 patients so far?
7. We did 7.
Okay.
7 cases.
You know, I think it's a fascinating idea. I mean, I really do like it. The one wild card I think you got there is the oscillation, because I mean I've been doing oscillating patients for 25 years, and I can tell you it typically will go in one direction, but sometimes it's the opposite direction, and sometimes you get absolutely nothing. In which case, I think in order to really improve your study, I would do oscillation on these folks ahead of time just to see what kind of response you get.
We did.
And
We did. We did.
okay, and I was going to say I'd only include ones that go in one particular direction. You know, as if you've got, for example, if you've got somebody who, well, you know, because I think that's going to add a level of variation that's going to dampen the possibility of finding some good results.
Yes. So we did the testing. We did the basic testing, including vibrations. We also hyperventilation and head shakes in these patients in that part. In the 7 patients, we did different things in there. So interesting part of the vibration is Dr. Ian Kurtholz, that he has nice publications in there. So I will try to put on the notes that the paper that is published in there. So you guys, if interested, look at this paper. This describes the methodology very well about what is the irregular, why he thinks is the irregular responses are responsible for the testing. So this is it's an open journal, so everybody can look at it and then see our thinking mechanism. But the interesting part, what we're seeing is we don't see the vibration response if the velocity storage, if we don't do the caloric testing. So the caloric testing, for some reason, creates a gateway for the certain fibers to pass into the reflex. So that's something that also Goldstein and Fernandez talks about these in their research. Not every stimulus that we get from our inner ear actually goes into the brain as a response. The brain has a gating mechanism. And during this caloric response, we open this gate and we start to seeing in some patients this reversal. We tried to get the reversal on the skating. After our 7th trial, that we get some reversal. It took 7 months that we did the caloric testing on that patient. He was still perfect. We just frustrated. We just kind of throw everything out. And the migrainer, you can't do much. It just on our thing there, she started profusely vomiting, and we thanked her, and she never talked to us again. So
If we go, can we go to the previous slide one more time, please?
of course, which one you like to see?
The previous one, the one
This
that
one?
has the protocol. Yeah, I think this is really a very good idea, because measuring the velocity storage can certainly help us clinically, and also understanding the physiology a little bit more. Now, we're assuming that all calorics will take that shape. But honestly, when you look at, say, caloric test done on the same subject several times, and I think I have data on that, but I don't have it handy here with me. Sometimes after the peak of the caloric response, the response can actually drop suddenly
Correct.
or can extend even way out. I think this is a great study, but introducing the vibration is kind of, if I look at this, you're saying that even they set up, you introduce vibration, and then they lie down supine again, and you're still getting a little bit of a caloric, a velocity storage response. But do you see nystagmus here?
Yes, we see
Yes.
that.
Okay.
See
Well,
nystagmus
this is fascinating, actually. If we can see nystagmus, what you said that here is about 3 minutes at the end here.
Yeah. Well, we can show you a very quick slides in there, so we can.
This
Oh
is
yeah.
really
Do you want to do
important.
that? Do you want to do your case and
Sure.
that
Let
may
me do the case, and then we can just go ahead.
Sure. Yes.
And then meanwhile, Christian can look at on those things, and then hold on. So this is a patient that I see, I think, approximately 2 years ago, and this is a carpenter come up with the episodic vertigo spells. He also has a hearing loss at the left side. He can't tell how long he has it, but he doesn't hear on that side, and he see quite a bit physicians around and there. So one thing is special on this episode of vertigo spells, which he can't work. He's very young. He has to support family. Because of those episode of vertigo spells, it comes out of blue, which lasts for at least 20 minutes. And he explains it as a spinning the world, vomiting, nausea, and feeling profusely tired at the end of the time. They lay him off. He can't find a job. He's terrible condition. So the neurosurgeons actually send the patient because he has a Chiari 1. He has some Chiari symptoms with the fingertip numbness, but not really serious. And neurosurgeon said, yes, you have a Chiari. It's been 7 millimeters, 7 or 8 millimeters, but this is nothing to do with that. So he saw the doctors in there. Some said, this is a Meniere. The other says, no, it is not a Meniere. You're very young for a Meniere. And so we did the testing on this. So you can see looks like there's a airborne gap, but I think it's because of the testing bias, could be because there's quite a bit loss. So the ear looks to us the normal. We did also the ECOG on her. If you can look at this side, can you concentrate here? Of course, there's a bias of a hearing loss there, but this is suggestive of a hydrops. See on the left side. So far, this looks like a endolymphatic hydrops and a Meniere. And then this caloric response. What the heck? So the good ear is actually the worst ear. Why? So I think we see this all the time is actually in our clinics. I think we all see this reverse things. There's different explanation for this. But this could be a sign of this could be something that's about that velocity storage. The storage is on that side, on the left, is actually abnormally holding longer. So that's the reason we're seeing the longer response, longer findings in there. So initially we tried the steroids on that. We did intradermal injections. We tried beta-histine. None of them has been helping. We put the patient in a low dose Diamox also, and 125 milligrams. He says, yeah, it helps some, but he was still getting the dizzy spells until we add venlafaxine. When we add the venlafaxine, 25 milligrams, he was happy. He found the job, the dizzy spells has resolved. And so here I will show you a video of that, of a head shake in there. Head shake is this something that we can think about that. Let me put it here. And then nothing happened. Here we go. Copy, paste. Here we go. Let's see. All right. So the way I do it, probably everybody is doing a little different. I usually shake the head for around 20 seconds.
Mm-hmm.
And then now look, after I did, so this is right. This is left. So this is unexpected. That's a very on the right nystagmus. So this is probably with the stimulating the irregulars. But then wait.
Which ear again, sorry, that has the linear
now, yeah, that's the left ear. And then you see that left nystagmus starts and lingers. Here we go, one more time.
And he had no spontaneous to start?
No spontaneous nystagmus on there. We can find the vibration result in him too. I have to look on the vibration, and then what we see in there. You see, you have a prolonged left nystagmus. That's last, how much we say? Almost 3-4 minutes. So after seeing that, that's probably it's more like a velocity storage issue with this patient instead of that thinking this only peripheral as a migraine. Because my next step was maybe do a gentamicin injection, but to do a gentamicin injection on a good ear like that, do that in there. So
the other
we're gonna disable the patients too, but he can't work on there.
Bulent,
but the vaccine worked like a miracle.
Bulent, I agree. Velocity storage could certainly explain, the calorics that you're getting, but another potential explanation is you got bilateral disease. I think bilateral disease frequently goes unrecognized.
But the hearing is completely normal if you look at
on the right side.
To me, that makes no difference. It really doesn't.
And the ECOG is also normal. Perfect on that side too.
Yeah.
I think
like I said, there are different explanations. I'm not telling that your explanation is not
the patient?
There are different ones in there on that part, but we bring in another explanation to think about that. That's the whole idea of what we are doing. When we are looking at the things, we're gonna get better results, better understanding our patients if we can see the other points also. That's the whole idea in that part.
Was the patient asymptomatic in between his attacks? From the balance point of view, did he have any problems with subtle imbalance?
No, he's normal. He does everything in that part, but different things was triggering his symptoms. He wasn't able to work. I
And
mean,
he's free of his headaches now too.
yeah. I forgot the headache part in there. Yes, he's feeling much better.
See, my contention is that most Chiari patients have Chiaris because of either increased intracranial pressure or intermittent increased intracranial pressure, which to me also you getting that transmitted to both your ears as well. Again, I would be really suspicious you got a bilateral problem. Although, like I said, it certainly could be explained by the theory you espoused, but something to kind of keep in mind. I think, lowering the pressure with the Diamox, certainly a big difference. The venlafaxine, I think, makes a lot of sense. But at the same time, too, that's treating both ears at the same time.
Well, this is almost 2 years now. There's no change on the hearing, but 2 years is not a long time for a patient like that. So this is going to be a long, long time, and we'll see it maybe at 5 years. If you have a chance to look at this patient after 5 years, see where we are, how we're doing. So the whole idea when the patient come to me or Dr. Gianoli, they want to get better. They want to function on that part. Use all your talents in there, information out there, but use your things so I can go back to work. I can support my family. I can do the stuff in there. So that's what's the idea. So here we were bringing in with the general knowledge of the basic science. We did our best to maybe we can integrate some of the things in there, maybe try to give an explanation from that level. So that's all we tried.
I think if we look at the caloric test on the left side, I would term it as a hyperactive, and that's why the vestibular suppression helped. The right ear seemed to be reasonable. So this is a kind of an asymmetric caloric response, not because the right ear is down, but because the left ear is overactive. Now, did the patient during the caloric suppress the vestibular-induced nystagmus? I think the Chiari is playing a role here. And the Chiari is indirectly involved in the storage mechanism because it goes through the cerebellum. And I doubt the Meniere's diagnosis here because the hearing loss, again, I haven't seen the other tests, but I'm sure, Bulent, you from the history, were you convinced that it is a Meniere's case?
No, I'm not going to say that full diagnosis is the Meniere or not. I don't see the typical thing that this is on there. We didn't go over time. I think the left ear responses will gonna be going down. That maybe we will start to seeing also some weaknesses on that side. But our goal is there to bring life to this guy because he's 43. He can't work. He can't go back. He can't go back to the desk job. He's an outside worker. He does this, I think, carpenter job and the other things. He can't just go back and hey, you're 43 in there. So diagnosis part, yes, we can go to the criterias, possible mini. But to me, it's not that important. He has a hearing loss, we know. He has Chiari, we know. But more importantly, on our tests we didn't see a significant vestibular weakness in the test, also the biasic. So we didn't do the Caloric twice. We did one time, and then this is not an experiment also, you have to understand. This is just a clinic. And for many clinics, 20% difference between right, left. We didn't know, okay, come in there.
And you've injected him with the gentamicin 40 milligrams?
No gentamicin.
No.
We never did
the patient got better with medical therapy. Yeah, with the Diamox and
we tried steroids only. Steroids.
You can't
You
do that.
know,
You don't know which year it is, so you can't use gentamicin because you're not positive which year it is.
Oh yeah, no.
I think
I
I think
That's,
most point is very, very interesting. We've always had the assumption you do calorics, the good ear, the high ear is normal, and the lower ear is bad.
not
Maybe that's
necessarily.
yeah, that's
so
exactly right. It's exactly the point I'm making. It's possible. Maybe some disease is irritative. So it is like, and maybe that's what's going on. The cerebellum's job is to suppress. That's all the cerebellum does, suppress, suppress, suppress. So if you, maybe because of the Chiari or maybe because of the vestibular abnormality, it is no longer appropriately suppressing this velocity storage mechanism, whatever it is and wherever it is, it's no longer suppressing it and giving the patient symptoms when it flares up.
so to your point, Art, I had a patient this week that Bulent's case kind of reminds me of. It was a lady who had bilateral superior canal dehiscence, and on the left side, it was a massive dehiscence. Like there's like almost no canal there. And
Jeez.
that's really the other side, the right side was mostly asymptomatic. The left side was the symptomatic side. And on the caloric test, that symptomatic side gave hyperactive calorics. I mean, like just the warm caloric by itself was 75 degrees per second.
Wow.
Wow.
Yes.
And I don't, it turned out to be a caloric weakness to the good side, like this
Right.
case. But it was obvious, both talking to her and, just, you put a little pressure on her ear, her eyes will roll, as if you're directly stimulating her superior canal. She had, a vamp of, 65 decibel, threshold, C vamp and just an
Gee.
outrageous O vamp. But I was very impressed with that caloric test more than anything else. 75 degrees per second was
75
just
degrees
high.
is so high,
And she
Jerry,
did
that
not have a caloric, excuse me, she did not have a Chiari. But I've seen this occasionally with the third mobile windows where they get this hyperactive
yeah.
caloric response. And I don't
Yeah.
understand why that's the case. The only thing that makes sense to me is that are they getting so stimulated that it's affected their velocity storage mechanism, sort of in line with what you're talking about here. Um, which also kind of in your case, you've got that low frequency airborne gap, which makes me wonder, do you have like some atypical third mobile window on that left side?
we have CTs and MRIs on there that looks normal on there.
Mm-hmm.
Can go back and then try to find it on there, but there's no question on that part. We have a CTs, we have all of them that I feel like that little airborne gap could be something else, but also could be the biotic too, because that's a 50 dB change sometimes. So I try to I don't really concentrate on that one that much on that level.
The other point is the velocity storage is frequency dependent as well.
Yep,
Yeah.
absolutely.
Yeah.
Low
So
frequency.
and the migraine, if they didn't dump when she or he sat up, is because of the hyperactive caloric response. You see what I mean?
Yes.
Because in
Yeah.
your migraine, sitting did not reduce the velocity storage, or perhaps did not reduce even the nystagmus in that patient. But it's a fascinating subject. The velocity
Yeah.
storage mechanism is important.
One other question, Bulent, when y'all did the oscillator for your pilot study, where did you place it? Did you place it vertex, mastoid?
Oh, we tried to sternocleidomastoid the muscles
Oh,
on that, and we
Oh,
also put it on the mastoids on the
okay.
belt sides. We put it on the posteriorly, where we kind of put it on a different spots to
Well,
get the response.
I,
And
I
the
did
think
it
different
make a
angles.
difference?
I think the study would is definitely worthwhile doing. But
Yeah.
I would recommend two things. One, I would do I would make a standardized place where you did the oscillator. I wouldn't vary it. I would either just do vertex or just do the mastoid on the caloric side you're doing. And then the second thing is I would screen them in advance
We did.
with the oscillator
We did.
and just make it routine. Only ones that go left versus right, just to eliminate that variable.
Yeah, we did. We definitely we did
Okay.
a isolation. We did also head shake
Yeah.
before we do that.
Try to do
That's good.
comparison between doing the study sitting up only and doing the study sitting up and mastoid oscillation.
So interesting things is that before I was there, I was cleaning a simple mastoid right before we started, and then I try to clean it with I usually use it the old way. I put a little bit of cut, has a large, nice mastoid cavity she has. It's just a little bit, I make it a little wet, let a little bit of antiseptics or whatever I have on the clinic. So I apply, when I cleaning in there, I applied also some over this lateral canal to take off some of that. And patient immediately gets dizzy. Immediately. There's no dehiscence or anything. I see that on that part. I have a CT scan of that patient. And then when I put the patient up again and put the head down, we immediately can dampen. So it's another example that how we sometimes see the velocity storage in these patients.
Yep.
Mastoid cavity patients, some of them, they hate the suction because suction causes a little cooling on that part, position, and you trigger them there, the immediate caloric response.
Yeah.
And then instead of waiting there, having them sit up immediately, put the head down, that dumps. This is exactly what the basic science is, Dr. Cohen and forgot his name always.
Rafan.
Huh?
Dr. Rafan. Cohen and Rafan.
Yeah,
Rafan. Yeah.
On the monkeys. So that's
Rafan and
kind of we are
Bernie Cohen.
integrated.
Yes, it was Bernie Cohen who really is the one that proposed the velocity storage.
Yeah.
He rest in peace now.
Okay.
I agree. I think you should keep doing the mastoid. The team of Ian Courtois, he's working with a French guy named Georges Dumas, and they were sort of standardizing it. They'd skull vibration-induced nystagmus.
Yeah. Well, I did read the Dumas papers.
Yeah.
I recommend strongly looking at the Australian researcher. I put it onto the notes in there. That's a very nice particle. He just published it last year, I think. And read this also, Ian Courtois. He's a very well-known scientist from Australia.
Yeah, he's great. He's great.
Do you have access to sinusoidal harmonic acceleration, Bulent?
We can not do it in our spot. I'm in the Little North area. We have the balance center down, but it's an hour away, and many patients hates to go there.
Yeah.
To them. So we do the ECOX here. We do the hearing. What do you do? VNG, and there we have a very good on that part. But for color, and we can do the posterography, but we can't do the rotatory testing.
I think if you do the
down states.
If you have access and you do low frequency step testing and high frequency step testing, that may answer some more questions. As a matter of fact.
Absolutely.
Right.
And there are good videos. I think some of them you also help them to produce. That would
be very interesting.
Yeah, that's a good thing.
Yeah.
Is there any other questions that from the audience, or
I have a question to the medical student because I am pro medical students. I congratulate you because you're a second year, right?
Yes, sir.
Yes, sir. You are wonderful to actually do a research on a subject. As you can see, the experts are still kind of not agreeing on everything. Did you have any background before you started medical school?
Not particularly in vestibular things. When I in my
Engineering, physics, anything?
no,
No?
neuroscience broadly, doing stuff in rats in my last year of undergrad. Um, but th those were more pacemaker things. But the whole idea of the neuronal potential, stuff like that, I have some background, but Dr. Mamikoglu was incredibly helpful and
No, it's
patient.
really
Well,
great. Really,
I'd like to
good luck.
I'd like to say the same thing that Mo did. When your background is great, but it doesn't really matter. I tell medicals, I'm going to be teaching a medical student later on today. I tell them there's 4 things you have to do if you want to find out about vestibular pathology. You have to sit down, you have to shut up, you have to listen to the patient, and you have to think outside the box. If you do those 4 things, you're going to come up with a good theory. And your theory actually makes really, really good sense, because patients come in, this sort of velocity storage thing, we're not suppressing it. Patients will come in, and I'm sure Jerry and Mo will allude to this as well. They'll come in and they'll say, when I turn my head, it feels like it takes my eyes a few seconds to catch up. So in other words, the velocity storage is usually suppressing any further movements, or is adjusting. Like you said, it's run by the otoliths, adjusting any corrections once I turn my head. If you can't do that, then you say, holy smokes, my velocity storage is not working properly. I have to zero in over there. And who are very, very good at doing that? Figure skaters and dancers are very good at doing that, because they are trained to fixate on something in the crowd. They're trained to spot. And what that's doing, I think, is fooling the velocity storage into saying, you don't have to make any corrections, because when I'm not moving, because I keep looking at the same person in the crowd every time I spin. So my velocity storage isn't necessary. That's what they're doing. That's why you don't see any post-nystagmus. That's just my thought.
Art, we don't want the terminology of velocity storage to become a velocity storage disease like the PPPD.
No, I know. Yeah, it's a label. I don't want labels. Don't put a label on patients.
Well, we have enough of that already.
Okay. Oh yeah. Okay. Say the bit. You have a really, really nice nice forehead. I'm going to put a label on it. Don't put a label on your patients' foreheads. Just tell them there's something wrong that we don't quite understand.
Well,
and very quickly, before we go, very quickly, why don't you send me your manuscript? Send me your paper. I'd love to have a look at it and give you, I've got a couple other comments I can make. So if you want to do that, art@melanson.ca.
Thank you very much.
One other, I want to just, again, also congratulate Christian. You did a great job. And, I tell you what, if you want to be the expert in the field of velocity storage mechanism, if you stay on it, you're going to have the whole field to yourself, buddy.
Yeah, that's.
I guarantee
the kind words.
10 years from now, you'll be the man. You'll be the man.
Why is this weirdo interested in that?
Hey, but it's arguably one of the most important things that's really not getting a lot of attention in the scientific community.
Yeah, totally.
Absolutely. Well, guys,
okay, well, thanks. Thanks for this, Jerry. This is great.
We're right up on our 1 hour, and thanks everybody for joining in, and thanks for Bulent and Christian for a nice presentation.
Christian, good luck.
Yeah. Thank you.
Yeah, keep in touch. Keep in touch for sure.
We don't see you,
Art, can you send me your email too?
Yes, I'll do that. I'll do that for sure, Bulent.
Okay, thank you.
I'll send you a note. Okay.
All right, guys, we don't have a time yet for our next meeting, but we're going to do a Friday in April. We'll send out notices. And if anybody is not on the email invite chain, just send me your email. I'll add you to the Zoom invites. And my email is just ggianoli@gmail.com. And we'll see y'all next time. Good seeing you guys.
Thanks, Jerry.
Thank you all.
Okay.
Thank you.
That's been great.
Okay, bye.
Bye.